Hi everybody, and welcome to our module on inborn errors of metabolism. Inborn errors in metabolism are defects in metabolic pathways. Usually they involve an enzyme deficiency, and they often present in the newborn period, and they often present in babies with non-specific features like failure to thrive or hypotonia. Babies can't give a detailed history, so normally all you get is a general impression that the baby is not doing well. And the way you're often asked to make the diagnosis of one of these disorders in USMLE questions is by using the lab findings, things like hypoglycemia, ketosis, hyperammonemia, and lactic acidosis. So in this video, we're going to talk about a number of these disorders and how to make the diagnosis. All of these disorders are discussed in detail in other videos, but here we're going to pull them all together and talk about how to sort out a problem where you're faced with a baby who's got a number of these different lab findings. Let's start by talking about newborn hypoglycemia. So all of the metabolic disorders I've listed on this slide can potentially cause newborn hypoglycemia. So in the next few slides, we'll go through them one at a time and talk about how to identify the exact cause of newborn hypoglycemia. Let's start by talking about the glycogen storage diseases. I talk about all of these disorders in detail in the video on glycogen. What I'm going to focus on here is how to recognize these disorders and distinguish them from other metabolic problems that occur in newborn babies. So first of all, you should always remember that some glycogen storage diseases do not cause hypoglycemia. These disorders only affect muscles. These include McArdle's disease and Pompei's disease. So if you're faced with a board question of a baby with hypoglycemia and you see one of these two answer choices, those are not the correct answer. There is, however, hypoglycemia that can occur in other glycogen storage diseases, especially in von Gerk's disease and Cory's disease. So let's talk about how to recognize these two glycogen storage diseases now. So babies who have a glycogen storage disease develop fasting hypoglycemia, and the key word is fasting. They can't break down glycogen to maintain their blood sugar levels in the fasting period. So the hypoglycemia is going to present hours after eating, not immediately after eating. In other words, it won't present in the postprandial period. In addition, babies with glycogen storage diseases who develop hypoglycemia have ketosis. Because there isn't enough glucose around during fasting, they will break down fatty acids, and this will lead to ketone synthesis. And this is an important feature because, as we'll talk about later, in fatty acid disorders, there can be hypoglycemia, but there will not be ketosis. The presence of high levels of ketone bodies indicates that fatty acid metabolism is occurring normally. And then finally, in the glycogen storage diseases, you can see hepatomegaly. That's because glycogen builds up in the liver. In von Gerk's disease, or type 1 glycogen storage disease, there is severe hypoglycemia. This is because gluconeogenesis cannot occur normally in the liver, and I explain why in the video on glycogen. In addition, in von Gerk's disease, there is a lactic acidosis. This is because of disruption of the Cori cycle. The bottom right side of the screen, I have a drawing of the Cori cycle. Muscle cells and other cells produce lactate, and they send that lactate back to the liver. The liver converts it into glucose and then sends glucose back to muscle cells and other tissues. If gluconeogenesis cannot occur, then the liver cannot export the glucose. Therefore, this cycle backs up, and you will see high levels of lactate and a lactic acidosis in the plasma of children who have a type 1 glycogen storage disease. In Cory's disease, which is a type 3 glycogen storage disease, these babies have problems breaking down glycogen, so they become hypoglycemic. However, gluconeogenesis remains intact. Therefore, the hypoglycemia is milder and the Cori cycle is not disrupted, so there is no lactic acidosis. Now let's talk about hereditary fructose intolerance. This disorder I discuss in greater detail in the video on galactose and fructose, but by way of review, in this disorder there is a deficiency of the enzyme aldolase B. This leads to buildup of fructose 1-phosphate, and because fructose 1-phosphate contains phosphate, it will deplete ATP in liver cells. This will shut down gluconeogenesis and glycogenolysis. In other words, in order to synthesize glucose or break down glycogen, you need ATP. And because ATP is depleted in this disorder, babies who have this problem cannot perform gluconeogenesis and cannot break down glycogen. So they will develop a clinical syndrome that is similar in many ways to the glycogen storage diseases. They will have hypoglycemia and lactic acidosis and ketosis, and they can even have hepatomegaly from glycogen buildup. So how are you going to distinguish this disorder from a glycogen storage disease? Well, first of all, fructose intolerance presents just after babies are weaned from breast milk. That's because there is no fructose in breast milk. So a classic presentation is hypoglycemia in a baby who was just transitioned from breastfeeding. The second finding, the one that's used in clinical practice to diagnose these disorders, is the presence of reducing sugars in the urine. So reducing sugars are glucose, fructose, and galactose. Now in a hypoglycemic baby, You know that any reducing sugars you find in the urine do not represent glucose because the baby has low glucose levels. Therefore, if you see reducing sugars in the urine of a baby who is hypoglycemic, that means fructose or galactose must be in the urine, and this is the hallmark of hereditary fructose intolerance. Classic galactosemia is a disorder of galactose metabolism, but it shares many features in common with hereditary fructose intolerance. So in classic galactosemia, which I discuss in greater detail in the video on fructose and galactose, is caused by a deficiency of the enzyme galactose-1-phosphate uridyl transferase. This leads to accumulation of galactose-1-phosphate in liver cells, and that depletes the supply of ATP. So just like in fructose intolerance, this is going to shut down gluconeogenesis and glycogen breakdown. In contrast, however, to fructose intolerance, which presents when the baby is weaned from breast milk, galactosemia presents in the first few days of life. That's because breast milk contains lactose, and lactose is made up of galactose and glucose. So this disorder will present in the first few days of life with a baby that develops vomiting and diarrhea after feeding. It's going to occur just after feeding because that's when the glucose is taken up by the baby and it can't be metabolized. Otherwise, it's going to have a similar presentation to fructose intolerance. There will be hypoglycemia, lactic acidosis, ketosis, hepatomegaly from glycogen buildup, and reducing sugars in the urine. So here's a summary slide to emphasize some of the key points we've just discussed. When you're faced with a problem of a baby who has hypoglycemia and lactic acidosis and ketosis, that can represent a couple of different disorders. If it occurs just after feeding, then it likely represents galactosemia or hereditary fructose intolerance. If it develops during the fasting period, then it likely represents a glycogen storage disease. And remember, in these two disorders, you will find reducing sugars in the urine. That's how the diagnosis is made. Now let's talk about the organic acidemias. These are disorders in which there is abnormal metabolism of some organic acid. There are a number of these disorders, but the two that you should be familiar with for step one are the organic acidemias that involve propionic acid and methylmalonic acid. We'll talk about both of these in a minute. In these disorders, there is buildup of organic acids in the blood and urine. That leads to an acidosis. And then the second feature you should know about these disorders is that they cause hyperammonemia. The mechanism of this is not entirely clear. It's believed to involve shutdown of the urea cycle, but if you see a newborn baby who has some unexplained acidemia and hyperammonemia, these are one of the disorders you should think of. To understand these disorders, you need to appreciate that succinyl-CoA is a common pathway to the TCA cycle for many substances. All the substances shown on the bottom left of the screen here can be metabolized into propionyl-CoA. So this includes a number of amino acids, also cholesterol, and also odd-chain fatty acids. All of these things can be metabolized to propionyl-CoA. Then via an enzyme that requires biotin as a cofactor, propionyl-CoA is converted to methylmalonyl-CoA. And then via another enzyme that requires vitamin B12 as a cofactor, methylmalonyl-CoA is converted to succinyl-CoA. So in the organic acidemias, one of the steps in this process is disrupted due to an enzyme deficiency. So in methylmalonic acidemia, this enzyme is deficient. As a result, all of these molecules are funneled into methylmalonyl-CoA but then cannot go any further, and therefore methylmalonic acid builds up in the blood. In propionic acidemia, all of these substances at the bottom of the screen here are metabolized to propionyl-CoA, but they can't go any further because this enzyme is deficient. That leads to high levels of propionic acid in the blood. The organic acidemias generally present in the newborn period, usually the first few weeks or months of life. The babies will develop non-specific symptoms like poor feeding, vomiting, hypotonia, and lethargy. These babies can have hypoglycemia, which can lead to ketosis. The mechanism of this is complex, but it's believed to involve liver damage from the acids that shut down gluconeogenesis. These babies will have an anion gap metabolic acidosis. That's because one of the organic acids is building up in the plasma. That causes an acidosis, and the type of acidosis it causes is an anion gap metabolic acidosis. And then, as I mentioned before, these babies will have elevated ammonia levels. That's often a tip-off that the problem is describing an organic acidemia. And then the hallmark of these disorders to make the diagnosis is to identify elevated levels in the urine or plasma of one of the organic acids. So in propionic acidemia, there is deficiency of an enzyme called propionyl-CoA carboxylase. This is a biotin-dependent enzyme that metabolizes propionyl-CoA. When this enzyme is deficient, levels of propionyl-CoA build up, and then propionic acid dissociates from that and leads to an organic acidemia. In methylmalonic acidemia, there is deficiency of methylmalonyl-CoA mutase. This is a vitamin B12 dependent enzyme that converts methylmalonyl-CoA into succinyl-CoA. Methylmalonyl-CoA and succinyl-CoA are isomers. They have the same chemical structure. The atoms are just arranged differently. So if a baby is deficient in methylmalonyl-CoA mutase, the levels of methylmalonyl-CoA will build up, methylmalonic acid will dissociate, and you will have high levels of methylmalonic acid in the plasma and urine. Let me briefly mention maple syrup urine disease. I discussed this disorder in greater detail in the video on other amino acids. This is a branched chain amino acid disorder. The branched chain amino acids are shown at the bottom of the screen. They are valine, leucine, and isoleucine. They all have side chains with branching. And in maple syrup urine disease, these amino acids cannot be metabolized due to deficiency of an enzyme called alpha ketoacid dehydrogenase. This is a multi-subunit complex enzyme. It requires cofactors like thiamine and lipoic acid. And the way that these three amino acids are metabolized is that they are first converted into structures called alpha ketoacids, and then this enzyme, alpha ketoacid dehydrogenase, dehydrogenates the alpha ketoacids. So when this enzyme is deficient, what you have in the plasma and urine is buildup of the branched chain amino acids and their corresponding alpha ketoacids. And the alpha keto acid of isoleucine gives urine a sweet smell. It also gives the earwax and the sweat a sweet smell. And this is often the tip-off that the question is describing maple syrup urine disease. Now let's talk about fatty acid disorders. I discussed these disorders in greater detail in the video on fatty acids, but in this video I'll focus on how to recognize one of these disorders and distinguish it from other metabolic disorders in a newborn baby. So the two key fatty acid disorders that you should know are a carnitine deficiency and an MCAD deficiency. MCAD stands for medium chain acyl-CoA dehydrogenase. It is a beta oxidation enzyme, and when it is deficient, beta oxidation does not occur normally. Both of these disorders cause hypoketotic hypoglycemia. This is a very unusual finding. When there is hypoglycemia, there should be high levels of ketone bodies, but that does not occur when there is a problem with fatty acid metabolism. When there is a lack of fatty acid breakdown, that leads to low ketone bodies, and because there is not proper fatty acid metabolism in these disorders, there is overutilization of glucose, and that leads to hypoglycemia. In addition, there's not much acetyl-CoA around in these disorders because fatty acids aren't being broken down and they produce acetyl-CoA, therefore there is decreased gluconeogenesis. So for all of these reasons, you get the unusual finding of low levels of ketones in the setting of hypoglycemia that should never occur if fatty acid metabolism is working. The symptoms of fatty acid disorders usually occur with fasting or illness. These are times where fatty acids are needed as a fuel source. In newborn babies, these disorders usually present from 3 months to 2 years of age. That's because frequent feedings in the first 3 months of life often prevent fasting and therefore hold off the symptoms of these disorders. The symptoms that develop are generally nonspecific, things like failure to thrive, altered consciousness, hypotonia. These babies can have enlarged livers from fatty acid buildup in the liver. They can also have enlarged hearts from fatty acid buildup in the heart. But the key feature of these disorders that's going to help you recognize it in a board question is hypoketotic hypoglycemia that only occurs when there's a problem with fatty acid metabolism. I discussed primary carnitine deficiency in greater detail in the video on fatty acids, but I'll briefly review it here. So carnitine is necessary for the carnitine shuttle, which is an important element of fatty acid metabolism. Carnitine links together with fatty acids to form structures called acylcarnitines, and these move fatty acids into the mitochondria for metabolism. So if you look at the bottom left side of the screen, I've shown the structure here of acyl-CoA. So acyl-CoA is a long hydrocarbon linked to coenzyme A. So the R here is a hydrocarbon that came from a fatty acid. Maybe it's 5 carbons or 10 or 15 or even more, and it's been linked to a CoA to form a structure called an acyl-CoA. Acyl-CoAs are linked up with carnitine to form acylcarnitines, and these are the structures that move into the mitochondria for metabolism. So when a baby is born with a deficiency in carnitine, that baby will have symptoms like muscle weakness and cardiomyopathy. This is because you need fatty acids for metabolism in your muscle cells and in your heart. But the hallmark biochemically that you will use to make the diagnosis is that the levels of carnitine and acylcarnitine in the plasma will be low. In an MCAD deficiency, there is poor oxidation of medium chain fatty acids. These are fatty acids that are 6 to 10 carbons in length. And the hallmark of an MCAD deficiency is the presence of structures called dicarboxylic acids that are 6 to 10 carbons in length in the urine. This is the structure of a dicarboxylic acid shown at the bottom of the screen here. Fatty acids normally have a carboxylic acid group at only one end. A dicarboxylic acid has a fatty acid group at the other end as well. The reason this happens is because anytime beta oxidation is impaired, an alternate metabolic pathway called omega oxidation will occur, and that leads to the addition of a carboxylic acid group to the other end of the hydrocarbon. The result is formation of dicarboxylic acids. These are a sign that beta oxidation is impaired. And then the other finding that you'll see in an MCAD deficiency, which helps distinguish it from a carnitine deficiency, is that the level of acyl carnitines of medium chain length will be high in an MCAD deficiency, and this is in contrast to a carnitine deficiency. So here's another review slide just to emphasize the important points. When you see hypoketotic hypoglycemia, they are telling you that something is wrong with fatty acid metabolism. In a carnitine deficiency, the carnitine levels are low and the acyl carnitine levels are low. In an MCAD deficiency, you will see high levels of acyl carnitines and you will also see dicarboxylic acids. Now let's talk about urea cycle disorders. I discussed these disorders in greater detail in the video on ammonia, but by way of review, these disorders usually develop in the newborn period, usually in the first day or two of life. This is because when the baby starts feeding, it takes in a protein load, and because the baby cannot metabolize urea, this leads to symptoms. The symptoms are usually nonspecific and similar to other metabolic disorders, things like poor feeding, vomiting, and lethargy. You can see seizures, but the key finding is on blood work. In babies with a urea cycle disorder, you will see an isolated severe hyperammonemia. So a normal ammonia level is less than 50. In a urea disorder, it can be greater than 1,000. And the elevated ammonia level is isolated, meaning there are no other major metabolic derangements like the ones we have discussed in other disorders. The most common urea cycle disorder is an OTC deficiency. Ornithine transcarbamylase is necessary to metabolize carbamoyl phosphate into the urea cycle, and ammonia is metabolized into carbamoyl phosphate. So when you have a deficiency of this enzyme, the level of ammonia will get high and the level of carbamoyl phosphate will get high. Now, carbamoyl phosphate is also an intermediate in the pyrimidine synthesis pathway, and it is metabolized to orotic acid. Therefore, when you have an OTC deficiency, in addition to high levels of carbamoyl phosphate and high levels of ammonia, you will also see high levels of orotic acid. And you don't want to confuse an OTC deficiency with another condition called orotic aciduria. This is a disorder of pyrimidine synthesis that I discuss in the videos on pyrimidine metabolism. It also has high levels of orotic acid in the urine and in the blood. However, in orotic aciduria, there is no problem with the urea cycle, so the ammonia levels are normal. This means there will be no somnolence in these babies, no seizures in these babies. The major feature of orotic aciduria is a megaloblastic anemia and poor growth. And the reason you get a megaloblastic anemia in orotic aciduria is because you cannot synthesize pyrimidines, therefore you cannot synthesize DNA and RNA normally, and that leads to a megaloblastic anemia. The last type of inborn error we'll discuss is a mitochondrial disorder. These are inborn errors of metabolism where you lose the ability to metabolize pyruvate into acetyl-CoA. Pyruvate is converted into acetyl-CoA in the mitochondria, so when the mitochondria are sick, this can't happen. This results in a severe lactic acidosis and an elevated alanine level. Alanine is an amino acid, and pyruvate is shunted to alanine when it cannot be metabolized normally. So if you can remember that an elevated alanine level suggests a mitochondrial disorder, it's very easy to recognize these disorders in board questions. One of the most common mitochondrial disorders is a pyruvate dehydrogenase complex deficiency, and I talk about that disorder in more detail in the video on pyruvate dehydrogenase. By way of review, pyruvate is the end product of glycolysis, and pyruvate is metabolized into acetyl-CoA in the mitochondria. So when the mitochondria are sick, pyruvate cannot be metabolized into acetyl-CoA. As a result, it will be shunted to lactate, and that will give a lactic acidosis. It will also be shunted to alanine, and that will give high alanine levels. Pyruvate can also be shunted to gluconeogenesis. Now, gluconeogenesis is limited because it depends on TCA cycle intermediates. However, in general, hypoglycemia is not a prominent feature of these disorders, and one of the reasons is because pyruvate can still be metabolized in a limited manner into gluconeogenesis. As I said before, I discuss a PDH complex deficiency in more detail in the video on pyruvate dehydrogenase, but by way of brief review, in this disorder, pyruvate is shunted to alanine and lactate. So the key findings which develop in infancy are poor feeding, growth failure, and developmental delays. These are all very nonspecific, but it's the labs that will suggest a diagnosis. The alanine level will be high, there will be a lactic acidosis, and there should be no hypoglycemia. I'll finish with this summary slide, and if you understand everything on this slide, it is very easy to recognize these inborn errors of metabolism in board questions. So if you're faced with a baby that has hypoglycemia, failure to thrive, and acidosis, that can be a number of different things. If there are urinary sugars in the urine, this suggests galactosemia or fructose intolerance. And remember that these two disorders usually have an onset of symptoms right after the baby feeds if the baby consumes galactose or fructose. If you are told that there are high levels of organic acids and elevated ammonia levels, this suggests one of the organic acidemias. After this, the next important step is to look at the ketones. If the levels of ketone bodies are high, this suggests fatty acid metabolism is working, and that's what is seen in the glycogen storage diseases. If you have hypoketotic hypoglycemia, remember that is a very unusual finding, and that suggests some problem with fatty acid metabolism. Also, if you see an isolated high level of ammonia, that suggests a urea cycle defect. And then finally, if you see high levels of lactate and alanine, that suggests the mitochondria aren't working, and you should look for some mitochondrial disorder as a potential cause. And that concludes our video on inborn errors of metabolism.